And Denise, you'll man the chat for the
Absolutely.
questions at the end. Okay.
Absolutely. Just going to give it a minute for the numbers of attendees to flip in, and then I'll start chatting.
Absolutely.
Great.
Well, hello, everyone, and welcome. On behalf of ORNAO, we are so glad that you could join us this evening, and we want to thank you in advance for taking your time out of your schedule to be here. Tonight's webinar will focus on air quality and surgical site infection, something that we're all working earnestly at trying to minimize as much as we can. It's been generously sponsored by STERIS, and we would like to thank STERIS for the support. And of course, now my phone is ringing at home. Sorry, hang on, just there.
No problem. We can't actually hear it in the background, so you're good.
Okay, I'll pick up again. We're excited to have Lena Fogel with us, and Lena has a great deal of experience. She's a seasoned healthcare leader with over 30 years of experience in various roles, with over 15 years as a perioperative leader, including educator, manager, director of nursing, very impressive, and consultant. During Lena's career, she's developed and taught various programs on topics encompassing surgical perioperative process design using lean principles. Many of us are familiar with some of those foundational concepts. And then patient safety, as well as leadership, workflow analysis, all aspects of surgical care, as you can well imagine, and the patient journey mapping, as well as clinical excellence and evidence-based practice. After the presentation this evening, there will be a live Q&A, so please feel free to drop your questions in the chat or jot them down, and we can go and have take off the mics and have a more interactive exchange. We'd love to hear from you. I know there are lots of people from the province of Ontario and some beyond Ontario, so we'll look in the chat to let us know where you're from, so we can get a sense of that. And with that, I'm delighted to hand it over to Lena. Please join me in extending a warm welcome. And on behalf of everyone from STERIS and ORNAO, we want to express our heartfelt gratitude for this incredible work that the healthcare providers in the ORs across the province and otherwise do every single day. Thank you, and enjoy the presentation on air quality and surgical site infection. Thank you. I'll hand it over to you now, Lena.
Thank you so much and for that wonderful introduction. And thank you guys for having me. It's my pleasure to be here and to present this webinar to you. We're going to talk about something that until a few years ago, where I really started researching air quality in the operating room, I didn't know a lot about. So I'm going to venture to guess that some of you may not be as versed on all the different aspects of air quality and how they impact patient outcomes. So that's what we're going to talk about today. And hopefully you can understand after we're done the mechanisms by which airborne contaminants are spread in the operating room. Some of you might be a little surprised by this. What are some of the quantitative measures of OR air quality in the operating room? And what are some strategies to control or improve the air quality in your operating room? And what kind of measures can you integrate into your practices? And this is about having the right equipment, but it's also about having the right behaviors. So we're going to talk about that as well. So let's level set our conversation by kind of talking about surgical site infections. What are the prevalence of those? What are some of the burdens and costs? If you've seen them firsthand, then you know very well how costly they are to patients that acquire them. And I got very interested in this topic because my brother was in a very serious car accident, and he ended up with sort of a lower body, lots of fractures, and he got his fractures repaired, but then he got a bone infection. And that really was one of those insidious low-grade bone infections that was very difficult to treat and heal. And, he never was able to walk after that. So very tragic. And I'm particularly interested in what we can do every day to prevent surgical site infections. So kind of taking a look at Canadian infection rates and incidences. It's estimated they occur in 2 to 5% of all surgeries in Canada. And given that you perform over 1 million surgeries annually, this could be extrapolated to suggest that you have between 20 and 50,000 surgical site infections annually. And those are infections that are strictly caused by the surgical intervention. Some of the higher risk procedures, and this will be no surprise to you, will be cardiac surgeries, particularly pediatric cardiac surgeries, hip and knee arthroplasties, and shunts and other areas where you're exposing tissue and cerebral spinal fluid. We all know that skin is our biggest barrier, so by the nature of our having surgery in and of itself, you're sort of removing the biggest barrier to infection that a patient has. It's estimated in Canada that the annual cost of treating and surgical site infections can be up to $1 billion. We know in Canada that SSIs increase hospital stays by an average of 11 days, and patients with SSIs have a 5 times higher chance of readmission after initial discharge. And they require 60% more ICU time than if they didn't have that surgical site infection. So very devastating for both hospitals, patients, healthcare providers, and the entire health system. They create a financial burden, a loss of quality of life and satisfaction. There's a lot of studies that estimate that surgical site infections carry about a 5% mortality rate. So 5 out of every 100 patients that gets a surgical site infection will die from that infection. They can create severe pain, insecurity for the patient around their recovery, healing, getting back to work, getting back to their normal lives, and increased risk of readmission, as we talked about, and higher mortality risk. For the same and like patient with the same comorbidities and surgeries, patients who develop an SSI are 2 to 11 times more likely to die than patients otherwise. And then there's a lot of emotional and physical burden on patients and families. So now we understand like how devastating a problem it is. And so what has been the history? How have we tried to prevent it in our past? Most of our preventions focus on physical barriers, right? So our surgical attire, physically scrubbing off bacteria from our hands, trying to reduce some foot traffic in the room, utilizing strict asepsis or sterile technique, and of course, sterilizing our equipment and other devices that we use. And that's been where we're focused. And one area that hasn't gotten enough focus is how we're managing airflow in the operating room, because numerous studies indicate that the decrease in SSI is due to improvements primarily, and I'll explain why, in the ventilation, sterilization barriers, surgical technique, and all of those things, and the effects of the operating room quality. The less pathogens or particles you have in the air, the less likely your patient is to contaminate their wound. So what do air ventilation systems do? They preserve the air quality and they dilute and remove airborne bacteria. When you hear about air exchanges in the operating room and they need to be 20 an hour, what that's really alluding to is removing air and replacing it with HEPA filtered clean air from the outside over and over constantly. That's what the air exchanges refer to. When you think about laminar flow, what we're really talking about is a unidirectional, high velocity airflow that is pushing particles down and away back through the return grills in the room. And I'll explain why that's so important to have that as well. So sort of what are our main culprits here? The main culprit is Staph aureus, probably no surprise to you guys, but who is the biggest shedder of Staph aureus around a room? What's the biggest culprit in getting that shed around the room? Well, it's all the people. It's the OR staff. You have skin squamies that are shedding constantly into the air, and those where Staph aureus can live very harmoniously on our closed and healthy skin, it doesn't do so well when it gets into an open wound. And we're shedding that at rates sometimes 10,000 particles per second, multiplied by all of our staff, and movement really impacts that. The more we move, the more we shed. And think about when the patient is most vulnerable, we first make the cut. That's when the room is the busiest. There's most people in there when we're setting up and shedding all of that into the room right before we cut the patient. And while we're trying to close, it becomes really busy again in the operating room. So really making sure that you do everything you can to remove those particles from the air. And those particles are what bacteria is catching a ride on in the air. And those are going to include good HEPA filtration, good ventilation systems, air exchanges, positive pressurization, and laminar airflow. And we're going to kind of talk through those things. So there is a connection between environmental risk factors and mobilization of those airborne particles, right? Even when you're donning a mask and a gown and a hat, we all know that air goes through the path of least resistance. So when you're breathing, and even if you do your best to breathe right through the mask, even the mask's woven technology isn't enough to prevent particles from escaping through your mouth and off from your skin. And the hospital air spreads four primary bacteria, studies have shown. 10 to 20% of nosocomial infections originate from patients, staff, visitors, ventilation, air conditioning systems, and outdoor air. So size really does matter. So bacteria measuring between 0.2 and 5 micrometers, they adhere to particle forming larger colonies known as colony forming units, and they catch a ride and they can stay suspended in the air, or they can, if they're heavy enough, they'll land on surfaces in the room, and those surfaces would be the back table, the wound, all of the patient care surfaces, your Mayo stand, and the ones that remain suspended are ones that can get removed from the room through the ventilation system. But as soon as you shed a heavier particle, laminar flow, that high velocity air continuously pushing down, can get rid of that out of the air before it settles on those back table and then through touch transfer into the wound. So larger particles are those ones that will not stay suspended in the air, and they are infectious. And we know that 40 to 70% of SSIs are caused by Staph aureus, so that's the bug of choice for them. And then the second one is the gram-negative bacteria, but overwhelming number of those cases have Staph aureus as the main culprit. And the environmental risk factors we're talking about is contamination of the wound that are caused by airborne Staph aureus. So one study showed that in cardiac surgery, up to 89% of wounds were contaminated at closure. That doesn't mean that person is going to get an SSI. However, they are at much higher risk because of contamination of their wound. And these wounds aren't getting contaminated primarily because anyone's doing anything wrong. They're getting contaminated because those heavier particles that bacteria is catching a ride on are falling into the wound, on the surgeon's hands, on the back tables, on the instruments. And the skin shedding by staph spreads the microorganisms into the air. That's what allows the contamination of the surgical wound. So some of the things that you could put in place to reduce this that are just behavior based are long sleeves in the operating room are really important because you're moving a lot and you're shedding. There's other things that we'll talk about, but that's one example. So only 2% of contamination comes from the patient's own skin. So all of this focus and effort that we put on prepping the patient's skin, while very important, you would be interested to know that accounts for a very small amount of the contamination. Contamination occurs indirectly by settling on surgeons' hands and instruments with touch transfer to the wound. That's about 70% of the time. And contamination by particulates settling directly on the wound occur about 30% of the time. And lots of studies show that 98% of contamination is caused by airborne bacteria. So if you're prioritizing or focusing on anything in your operating room that could be improved, let's say you do, and I'm sure you do, practice good aseptic technique and all those kinds of things, but who's minding the air, right? Like who's making sure that everything is in place for the air since it's such a large source of the contamination? Those are kind of the questions to ask, right? Deep SSIs increase as level of airborne contaminants increase. So when we're worried about deep SSIs, those ones that are causing the morbidity, mortality, burden, cost, all of those things, those are most likely going to happen when you have a lot of air contamination. The superficial SSIs might be associated with other environmental factors, but we do know that low airborne particles using an ultra clean ventilation system and laminar flow create a barrier around the surgical field that's very effective in removing airborne contaminants before they can settle on wounds, on back tables, on surgeons' hands, etc. So what do we want to do? We want to mitigate the environmental risk factors by eliminating as much as possible the bacteria from the operating room near and around the sterile field. And we know, I've already said that patients and the OR staff introduce microbes by shedding particles from their hair, skin, nasal passages, out of their mouths, even when they're breathing or talking. So a lot of extra talk, even with your mask up, will shed a lot. And so how does it all work? So we shed these squamous cells, often in particles that are large. Why does the large particle matter? Because that's the a size of particle that bacteria hitch a ride on that are heavy. Therefore, they won't stay suspended in the air. Therefore, they settle quickly onto all the surfaces that then contaminate the wound, right? And they circulate on air currents created oftentimes by temperature differences between the body and the environment. Think of the patient creating their own little weather system, right? Especially when you're using warming devices and the body and temperature around it is hot and the OR air temperature is cooler, you end up creating some turbulent air around the patient, and that allows these to circulate in currents around the patient and drop onto the patient. And so the rate of production and mobility of these contaminated particles highly depends on the number of people in the operating room, the level of activity in the operating room, and of course, proper attire to sort of shield the skin from shedding into the OR. So when you think about cases where, when you think about, I know we all try to keep the doors closed during total joints and we try to limit the traffic, but there was a recent study that did a time study on door openings. You would be so surprised to find out that on average, doors during a surgery case were being opened 27 times a case. So one kind of process improvement you could in place is to really do a time study, park yourself in the hallway and watch and log how many door openings there are. I think it's very eye-opening. It's a nice thing for a nursing council to assign to one of the nurses if you have a clinical ladder. And it's very eye-opening. Every time you open that door, your positive pressurization is reduced. The positive air pressure that's maintained in the room, it's higher, more highly pressurized than the hallway. That is designed so that when the door opens, the air in the hallway can't get into the operating room because the operating room is under a higher pressure and air leaves the operating room but doesn't come in. However, open doors really reduce that effectiveness. And every time the door is open, the positive pressurization goes down very quickly and bad air is allowed to come in. Also, sometimes for room turnover, I see people prop the door open so housekeeping can kind of come in and out. Maybe their cart is outside the room. That's probably not best clinical practice. It's probably best to keep that door closed between cases because you don't want the particle count to go up very high in between cases and be at its highest level right when the patient is rolling in the door and you're making the cut. So that's just another, I guess, helpful tip, I would say. And we already talked about size, so I will move past that. But the bigger the particle, the more bacteria and colony forming units it has on it, and the faster it'll settle on the wound. So for those bigger colonies, regular ventilation and air exchanges won't do the trick because by the time the air exchange happens, these particles have already landed on those surfaces and can create that touch transfer into the wound or go directly into the wound. So what's a person to do? And I'm going to tell you. So here are some sizes just for your own information. It's a little technical, but the main thing is this 5 to 100 unit measurement. These are the things that'll settle on surfaces. Your squamous cells are going to be of this size. And just know that they are of a size that can escape through the weave of your gowns and even your scrubs. They're, as we said, the skin squamous are the most important infectious particle. They originate from uncovered skins, gaps in cotton, and even your cotton scrubs, if they're at 80 they're going to allow a lot of particles to escape right through them. So cover up as much as you can, and all that good stuff. Okay. So movement displaces large volumes of air. I am going to quote AORN here, but I know that you guys have similar recommendations and requirements. So exposure to air may affect the sterility of open sterile items on sterile surfaces. So a lot of people, I don't know what your practices or policies are, but a lot of people think that if they open a table and they're not going to use it right away, they can cover it with a sterile drape and they'll probably be okay. That's not the best practice because, as I said, particles can escape through that weave and in the side. So try to use your instruments as close as possible to the time, try to open them as close as possible to the time of use. It's not good practice to have them open for any length of time. Now that we understand that we're not just talking about event-related sterility, where as long as you don't touch it, it's sterile. If it's exposed to the air, it is getting contaminated over time. When you think about forced air warming, if you're using something like forced air, bear hug, or anything like that, that hot air escapes out of that forced air. The hot air then collides with the cold air. That creates a little bit of a weather system and it creates sort of turbulent airflows that's circular, and that really helps facilitate particle movement around the room, which is bad, and that's the particles that are going to settle on your back tables and so forth. So be mindful that if you're using forced air, you probably shouldn't turn that on until you have drapes on top of that, at the very least. But just know that that is increasing your risk when that forced warm air escapes. So how do we measure these things? Well, the International Standards Organization does have a levels or standard around what ultra clean is, right? And this is the equation. It means less than 10 colony forming units per cubic meter, and surface contamination of less than 350 colony forming units. So I say that to tell you that there are standards around that. It is recognized, and that we do have mitigations. We're probably not going to go around measuring these colony forming units, but if we're doing all the right things, we should feel comfortable that we're providing the cleanest air possible, which is, after all we can do. So how do we get to that? How do we get to a very low colony forming count in your operating room and eliminate a lot of that airborne contamination risk? So to really do that, you've got to achieve air quality standards that look like less than one colony forming unit per cubic meter. And we're going to explore 4 techniques that can be employed to help you do that, right? So the first one is to remove contaminated particles through air filtration, right? So that's HEPA filters that are typically in your ceilings that air is flowing through and getting cleaned as it's coming into the operating room, which is very helpful. That's number 1. Number 2, we can prevent contaminated particles from migrating to the sterile field by using a very protective laminar airflow over the sterile field. Now, here's the thing. If you have laminar flow in your ceiling, the important thing is to make sure that your back tables and your sterile personnel stay inside the laminar flow, and that your non-sterile personnel, like your circulator, your anesthesia provider, get outside that laminar flow and don't go back and forth in between, in and out. Sometimes, you see circulators leaning really close to the field. They're probably in the laminar flow. Then they step out, then they step back in. Doing that creates a lot of air turbulence and interrupts that high velocity air, which can make particles like circle back in and land on top of the wound. So the rule of thumb is you're either in the laminar airflow or you're out of it. And if you're out, stay out. If you're in, stay in. And positively pressurizing the operating room is very helpful. But remember that those air exchanges really depend, and those positive air pressure really depend on having closed doors. Every time you open them, you reduce that effectiveness. Okay, so it really does depend a lot on how air is delivered, how you filter that air, and how many air exchanges you have in the operating room. So when you create that dynamic barrier, the airflow carries away the infectious particles and maintains a satisfactory air exchange. But not all laminar airflow is created equal. So there are some key differences to consider. So we're going to talk about the different kinds. You probably can look up in your ceiling and know what you have, or if you have anything. If you don't know what you have, you should find out. You should find out from your facilities people what exactly is installed in your ceiling so you can understand what is happening in your OR and you can take action around that. So for sure, a single large diffuser array provides an airflow for the patient and surgical team. Plus, it really needs to be 12 inches beyond the surgical table, if at all possible. So you want the surgical table to sit inside that. So if any of you guys are lucky enough or unlucky enough to build a new OR or renovate an OR, these are things to consider. You want to maintain your positive pressure at 20 air exchanges an hour, and you want your airflow to be unidirectional and directed down and out. That's really important that happen. So there are basically like in the design standards, there's basically like 3 airflow patterns in the operating room. One, and this is, forgive my little elementary drawing here, but one is turbulent, where the air is kind of circling around, going up and down and in and out. That is the kind that's in an OR that doesn't have laminar airflow at all. And that is your highest risk type operating room because there is nothing that is removing those particles before they have time to land on things if they're just swirling in a chaotic or turbulent fashion. Think of a windstorm and the wind is blowing in all different directions. Then there are things like horizontal laminar flow and then vertical laminar flow. And we're going to talk about the effectiveness of these things. So the horizontal laminar flow, as you see on the left-hand side, is really pushing air across the room, pushing it out from one vent and pushing it into a return vent on the other side. Unfortunately, these aren't the most effective. They're kind of old-fashioned, and these are the kind that will allow particles to stay suspended because they're not pushing them away from the surgical field necessarily. Your vertical laminar airflow directionally is the best because you want that those particles pushed down and out. That's kind of the best way to return them out of the operating room. And if you look at this, you can see that when it's horizontal, it's going to land all over the tables and surfaces, etc. Now, why a single large diffuser? And what I mean by that is, if you look up in your ceiling of the OR, you might see like, I don't know, 8 or 10 panels up there. That's usually a multi-array diffuser, where each one of those panels has its own, like it's pushing air down. But what happens there is there's air gaps in between those panels. And those gaps are causing turbulence and not a smooth removal of all of the air. So what are some things that also are a problem for traditional arrays of laminar flow? When you have disturbances on the edges, like equipment that's kind of sitting right where the laminar flow is going. And also physical barriers that are placed inside the path of the clean airflow. And I'm thinking of surgical lights, the domed lights. Those are in the way usually, and so the air has to go around those and down. So right under those lights, you might get interruptions in that airflow and gaps. And then heat. Heat is a problem there because heat rises, which takes that heated air with it up, and what we're trying to do is push it down and away. And you can see my little graphic here. That's what you would like to see happen. Those are all the little particles. So when you think of an air curtain, have you seen those? Those are those really old-fashioned laminar flows that look like sort of panels on the top in a square. These are the kind of particles you get with air curtains. All these little particles represent how contaminated that air is. When you get to a multi-diffuser array, better, but not great, because all those individual patterns create gaps in that airflow, which is just an opportunity for bacteria to come back in and float around. The single large diffuser, which is unidirectional with no gap in the airflow, is very good at getting those particles away from the sterile field. And that's kind of what that is here to represent. A little bit more about the airflow. The multi-diffuser array, you can see that there are gaps, and so particles are allowed to come back in. And on the right, it's very uniform how much we're able to push down and away. So the C that we're looking for, really, you want to eliminate the turbulence with those gaps, and then your low wall air return grills that most people have, you want to make sure those are not blocked, because that's how you're achieving your positive pressurization and how you're achieving the air exchanges. So sometimes when you're designing the operating room and you're thinking about where you're putting equipment and mobile equipment, just make sure you leave those free and clear in your room. Okay. And we talked about the air standards and the sizes. And this is the other thing that happens. People will cover just the patient bed with laminar flow, but they don't cover the back table or the surgeons. And the surgeons and assistants and scrubbed personnel oftentimes are sitting right on the edge of the laminar flow if it's too small in your room, and they're creating disturbances. So if at all possible, you want this laminar airflow section in your room to be big enough to cover not only the patient, but your assistive personnel scrubbed in around the patient, as well as your back table when possible. Now, it's not always possible because you might have a setup that's 4 or 5 back tables, but this is not an all or nothing proposition. All of these things are helpful. So there's a study where the unidirectional air delivery system was limited and the instrument tables were outside of the laminar flow. And the study did culturing of those tables and found a lot of contaminants on those surfaces. So increasing that ceiling coverage, as I was talking about, can reduce the contamination. Of course, there's a lot to consider there, but it is something that if you have the opportunity to do that, you really should. Some people ask, well, what if I have a protective suit on? Those are completely compatible with each other. The protective suit protects that physician's skin squamous from shedding around the wound. I mean, that's great, and we want that. But both of these systems combined carry the materials outward, right? Whether you have this hood on and you have the little vent, behind you, you still need laminar flow because there's many other avenues to contaminate the air beyond what the surgeons can provide by covering up. And then there was a study of air contamination rates between regular ventilation and laminar airflow, the single large diffuser, and it was found that we had an 89% reduction in colony forming units. That's better than regular ventilation in an operating room, and both of those are controlled with 20 air exchanges and HEPA filtration and all of the other things that are recommended. So even with all those things in place, the single large diffuser and laminar airflow really does help reduce contamination. And some of the airflow patterns in the operating room, they do depend on that continuous laminar airflow, the ventilation solutions, like making sure that you have HEPA filtration, making sure your low wall air return grills are unobstructed, and then some of the staff behaviors around how it is that air becomes so contaminated. So there was also studies performed that compared the effects of horizontal and vertical laminar airflow systems in reducing sediment and distribution of bacteria carrying particles. And staff clothing was also assessed. And so the results were that horizontal laminar airflow the horizontal laminar airflow performed better than having nothing, and we demonstrated an internal collection of equipment could have a serious effect on the movement of infectious particles. So don't use your operating room as a storage room if at all possible. The more equipment you have in there, the more opportunity for contamination to settle on surfaces, and the more opportunity for you to block that productive positive airflow or create turbulence or obstacles to that. So outcomes related to airflow patterns, the things that we're really looking at are how many particles are in the air and how many microbes are those particles carrying. We also want to know what proper humidity, temperature, CO2 does in those rooms, and we compared a single large diffuser, a multi-diffuser array, and a four-way throw diffuser. It's a little technical, but the results of the SLD said that the particle counts were lower. You had higher velocity of air, which is really important. You want high velocity air so it can push those microbes out. It did a better job at lowering the temperature in the operating room, which is helpful for all the people in the room. And it did a better job at removing microbes and carbon dioxide from the room. So making the case for that. Now let's talk about some of the staff behaviors. So the more people, the more airborne particles. So lower occupancy rates where it's feasible. That study I was telling you guys about where it was 27 door openings per case, they also documented what the door openings were for, and 46% of them were for no reason. They were somebody putting their head in, how are you guys doing? Did you guys go to lunch? Did you have a good weekend? I just wanted to say hi, that kind of stuff. That was for no good reason for patient care. And so be interesting to know how prevalent that is. But everywhere I go, I do see that. So not having people in the room that don't need to be there, trying to educate if you have a lot of interns and things like that. If there are other ways to do that without them being in the room the entire time, it would be helpful. Lowering room traffic, the people that come in and out, the people that are parked in there. And then, of course, just having the best air quality possible will be very helpful. Just so you know, there are commercially available particle counters that you can kind of do a spot check and see how your air is doing in your operating room. You could check it in a room that has been closed all day and you've been really minding after the proper behaviors, and one that has not, and see the difference. I think it's pretty easy to see with those particle counters. And so some of the recommendations that AORN has, and I think the Canadian Nurses Association mimics these because I was reading about them, but really position that surgical site and instrument tables within the air curtain of the laminar airflow system. Really try to have a visual indication of what is covered by that laminar flow system in your room. Some people use like the section that is covered, they have a different color tile. That might be black tile in the room versus white tile. If you want to do it down and dirty, you could outline it with tape, whatever you want, so that everybody understands what's in and what's out and what is causing a disturbance on the edges of that, right? You don't want people standing or walking between the airflow curtain and the rest of the room just because they're creating their own little weather system and turbulence. And imagine that they're under there creating that turbulence and shedding squamous cells at the same time. It's kind of a double whammy there. This is just to summarize everything we've talked about. That Staph aureus is the main cause of SSI. The main way that it reaches the air is via the skin squamous that are shed throughout the case. And once it becomes airborne, it settles on environmental surfaces. And maintaining low viable bacterial levels in the air has been shown to reduce the risk of SSI. And again, we want the size really does matter. I want to reiterate that those larger particles cannot get pushed out before they settle onto instruments and tables. So having high velocity airflow right where it matters is going to make a big difference here. Clean surgeries, if you want to perform them in an ultra clean atmosphere, then the ISO definition of that is right here. And the air quality really critically depends on your air delivery filtration system. And the single large diffuser delivers that ultra clean air that you're looking for. And then here are some of the references. I'll go ahead and flash those on the screen if anybody wants to, reference any of them. And this has been recorded. And with that, I am so happy to take any questions that anybody might have or anything further discussion anybody might want to do. And I just stopped sharing, Denise.
Thank you very much for that. I was just typing in. I'm not a very good typist, but I wanted to get a couple of questions in the chat. What I can say is I don't know if the Q&A is working all that well, so maybe the chat is a better option. And thank you so much, Lena. That was really great. You really highlighted a couple of points for me when I looked at in terms of the open doors. That drives me crazy. I'm always trying to keep them closed. And in terms of the temperature difference, I had never really considered that in terms of your own little weather system is a great way to describe it. One of the questions that I have in the chat is any suggestions in terms of keeping those doors closed except for the movement of patients and equipment, because I think it happens everywhere, and it is a big problem for sure.
Yeah, so I do have a few suggestions. I mean, we're all battling this, right? Because these all of our personnel and staff, they're there long hours, it starts feeling like home, and then a little bit of complacency sets in, And I think what I've seen really be effective is to, as I said, to spend a couple of days doing a process improvement study. It's a time study. You got your clipboard, you're parked in the hallway, and you're just documenting the case and how many door openings, and as best as you can ascertain what are the reasons, right? And then once you have that information, and I'm almost positive that it's going to demonstrate to you that doors are open too much, and that people aren't always doing healthcare business when they're opening and closing the doors. It's not 100% necessary. I think you'll find that if my experience tells me anything. So then what I would suggest is that at a staff meeting, you present the results, and because the people who can solve this for you are the staff. They know exactly how to prevent it. They know exactly what needs to be done. You just have to get their mind share around this is a real problem and this is why it's a problem. And a little education on, and it doesn't have to be too in depth, but you could lead off with a little education around air quality and positive pressurization and what that means and how open doors impact it. And then, by the way, we wanted to see kind of where we were, so we did a time study, and look what we found. So we have the same problem. That's a good way to do that. Some people, I see them post signs on the doors that says "Do not enter, surgery in progress," right?
Yeah.
So that can be helpful. And I see here the other question I'm looking at the chat is minimizing the movement of the sterile setups and tables from the outside where they're typically set up and then moved into the laminar flow. Yeah, so that's a really good question. So you're not going to escape from all of that, but let me tell you, when your doors are closed during setup, that helps because your positive preservation and your air exchanges happens. But I would not set them up until I'm extremely close to pulling them up to the field, right? We want to do this as quickly as possible. That's really all you can do. And the closer to the time you can set it up and get into the laminar flow, the better off you are. I see people unnecessarily set up early. I see in my practice, I used to see scrub techs that wanted to get in, set up so that they could take a break before the patient came in the room, right? And grab coffee and whatever. I get it, I understand it, but it's not good practice, right? That should happen before. Like, you shouldn't open until you're really ready to go. And you should communicate that with your circulator. And really, your circulator should drive that. Like, I want you to open now. We're coming in, etc. Yeah.
That
Good
makes sense.
question, though.
There's also a question from Tina. So thanks for the question, Tina, Niagara. It was suggested to wear long sleeves in the OR. And then I've never heard of a patient or warming unit clashing with the cold temperature. So I think there's a question around the long sleeves or a comment, and then as well, the turbulence that's created from that hot and cold temperature.
Yeah. Your arms are a big source. They're the things you're moving around the most. They're a big source of air contamination. You should cover all of your skin. I'm going to tell you a funny story. When I first started in the operating room, and we wore dresses, scrub dresses. I don't know if any of you guys ever saw that, but they had little scrub dresses you would wear. And for like the first year I was in the OR, we would wear dresses. And then a new rule came out that you couldn't wear dresses. And I was so offended because they said you couldn't wear dresses because of perineal fallout. That's what they called it. I'm not kidding. But they were right. And that's when we went to pants and to cover everything up. So long sleeves are really important. Covering up, no cutesy hair sticking out, this is little skin as possible showing. It's really important in the operating room. Your arms are a huge vector of contamination, unfortunately. Yeah. And then what was the other question?
The other question was really, I've never heard of the patient warming units being like causing that turbulence between cold and warm or hot, which I thought was quite an interesting
Yeah.
insight you shared.
There's studies about that. There's been a connection between that forced air warming and air contamination for the reasons I stated, because that hot air rises, clashes with the cold air, you get turbulence of the air, starts spinning in a chaotic way, and allows the opportunity for those contaminants to build around there and then settle onto wounds. So it's pretty well documented. I don't think there's a recommendation not to use it, but I think being aware of how it works and how that is a risk factor, like many other things in the operating room that we use. Nothing is really devoid of risk, but it's being aware of it and trying to mitigate as best you can. But yep, there are studies out there. I might have referenced one or two in the references page. So like feel free to take a look at that and see. But yeah.
There's a
We
really,
know.
go ahead.
Go ahead. I was just going to say, we know that SSIs are multifactorial, right? But that cannot be an excuse to then never do anything to try to mitigate it, right? Like we can't point and say this one thing caused SSIs, but it is our job to use evidence-based practice to do everything we can to reduce the risk of developing an SSI, which I'm going to say is preventable, right? Like if it's a preventable thing. And what I see a lot of people say is, well, like, it happened in ICU or it happened here, we couldn't do this or that. But we shouldn't become complacent. We are there as patient advocates. There are better practices and good practices and best practices, and we should always strive to do everything that we can in the operating room. And especially as the science evolves and the more we know, the more we need to do, right?
Yeah, and I completely agree in terms of education sessions like tonight. The more that we stay informed with the latest information, then we can keep each other accountable and make those shifts in practice if we've got some creeping going around. So this is great tonight. I'm just going to scroll up here. There was also a comment about keeping the doors closed during high risk phases, especially in arthroplasty or joint procedures for sure. But, I would add that every patient, because you don't know what risks that patient may have if you're not involved in their care. So we do have a surgeon that will sometimes put a sign up for his joints. Please don't come in. It's not,
I mean,
doesn't say please. Just don't come
yeah,
in.
right. What you could do is, because to your point, the length of surgery also increases the risk for obvious reasons, right? That's more opportunity for wounds to get contaminated, so forth and so on. But what I found to be effective in some places is not to leave it to the discretion of the surgeon and not to leave it to the discretion of the staff even, or to the patient's particular procedure. I feel like you can be more effective and compliant if you take a broad-based approach. We know open doors are bad, right? So we're not going to open doors, but guess what the benefits could be of that for you guys? If you did implement that, then it really kind of pushes preparation of the case, right? So if you know that really you shouldn't be opening the doors, you're going to make sure you have your supplies and the things you need before you start. You're going to do the things it takes to be able to successfully complete that surgery with the team you have in the room, and not need a lot of outside support once the case is going. So in the long run, having the simplest path to compliance is going to help you get that cooperation you need from the team. And so the more complicated it is, the more case dependent it is, the more surgeon dependent it is, the spottier your compliance, I think, is probably in my opinion anyway, for whatever it's worth.
I love that you mentioned that, because if we can be more prepared, then things will be more streamlined, and the flow of patient care is not as fragmented or interrupted. So very insightful. Thank you. You clearly have worked in an OR for many, many years. I love that. In terms of other comments that were made, what do you suggest for long sleeves? And it says undershirt, reusable overgown, scrub jacket. What are your
Scrub
thoughts?
jacket, scrub jacket. I think the undershirts, depending on the type of cotton or the type of weave or the type of whatever it is, like it's not well controlled. People put on thermal under stuff and all that. I think it's probably preferable to have a consistent standard with a scrub jacket. Maybe it's a disposable scrub jacket if you don't provide reusable ones. Those are pretty cheap and easy to keep. But I think scrub jackets, I do think that shoe covers, but I know that those are not always mandatory. But I think shoe covers are important because I've had my eyeballs on a lot of pretty gnarly shoes and socks out there. But specifically for skin shedding, I would recommend a scrub jacket and not a home undershirt. But if you wear an undershirt, that's fine, but you need to cover your arms with the scrub jacket. And be wary about a lot of neck exposure, right? It's nice to have that covered up. It's nice to have the mask fully unfurled and in as much as you can, but really I'm not going to name names, but like anesthesia, yeah, are not always the most compliant in these kind of matters. So it's really important to hold them accountable with the staff behaviors, but having the structural foundation to high air quality is probably the most important thing you can do. Make sure you have laminar flow. Make sure you have HEPA filtration, dedicated air exchanges, ducts coming into your room, unobstructed low wall grills. Keep those doors closed. Monitor your positive pressurization. Like they're going to go a long way for you if you're fortunate enough to be able to have some of those environmental things in your control. But in the meantime, cover up as much as possible. Yeah.
Excellent advice. And now I'm thinking about what kind of laminar flow we have, because I have a feeling, I think the OR is around 12 or 15 years old. So I think that I don't think that we have the single large diffuser. I think we probably have the
Multi-diffuser
And,
array.
So
if your ceiling looks like something in my picture here, then you'll see that that's an indication of a single laminar flow. It's the kind of the design of most manufacturers of these.
okay. I mean, I've certainly seen the really old ones that have the shield area. In the 1940s OR, that's still we still use it for
Yeah.
other things, but not for
Yeah.
surgery anymore. So really interesting to hear that. There are a couple of other comments. Somebody had actually put in here that some of the scrub personnel step out of the room during the procedures. I don't know what to say.
Yes.
I know what
And
could happen.
yeah,
Ashley.
here's what I'll say. That's an absolute no-no. But on top of that being a no-no, it's even a no-no for them to walk across the room for no reason, to walk over to computers or walk over to say hi. They've got their arms crossed and they're walking around the room. Huge no-no. Like that should not, that is really, really poor practice.
Yeah. So
Unprofessional practice, complacent practice, definitely not stepping. Why are they stepping outside of the room? Is that person comfortable staying?
X-rays, flat plates. Yeah. Levels for spine sometimes. I know that's been my experience. It no longer happens, but in this case, it's a flat plate. Maybe they have an incorrect count or something. I'm not sure, but
Okay, well, I mean, I think they should regown when they come back in. I know that's not as practical. Maybe they want to get in the corner room. Maybe you want to get one of those radiation shields on one of those apron radiation shields that sits on a cart that you can just cover with sterile drape and they can get behind that. There's got to be a better way than leaving the room. That's really not good practice. But
yeah. And we've had that happen. And I remember the staff saying, I'm like, what are you doing? You can't go out with that on. I mean, sometimes I'm very unfiltered. And I said, but let's think about what the options are. The option is to get another gown, right? So You can come out in your gown, but you can't go back to the table in that same gown because you've left the restricted space. So, you know, or say, here, I have another gown for you. Not
Right.
will you
Right.
change your gown? I have another gown for you. Let's get you
Yep.
changed, right? So how you approach that conversation and minimize the conflict for sure.
Absolutely. It should cause no conflict because we're all in it for the same reason. And if we just center all of our conversations around best practice and patient care, like they'll get it. You know, they may not love it, but we don't need them to love it. We just need them to get it.
We all know what the right thing is,
Yeah,
right? As long as we have the supports and
I
the
think
support.
I think you just found your next topic: patient safety unfiltered.
Yeah.
Back to
Patient
basics.
safety unfiltered.
I do like this comment here in terms of what are the savings in terms of SSI. You'd mentioned that it's upwards to $1 billion here in Canada. And there is, you know, there is a lot of literature as well as bundled care around prevention of harm. And even surgical site infections now are considered patient harm that are on some degree or level preventable. So the question is, did it show how much more it increases the potential for SSIs with each extra person in the OR, or is it just a general statement that the more you increase, the higher your rates?
Yeah, I don't think we've gotten that granular where we could quantify like one more person in the OR gives you a 5% more chance of getting an infection. I don't think we can go there, but we know that SSIs cost about $50,000 more in additional care for the patient, inpatient care days and all of those things. So the costs are very high. And, you know, there's no way to quantify each individual factor, but we know the bundle of behaviors and preventative measures work. We know that they work. And I guess that's how to focus that. Yeah.
Lori Boyer, I don't know where Lori is from because I can't see where she's from. I think she actually said hello in the very beginning. So let me go back now. North Bay, thank you for joining us. It must be beautiful up there right now with the leaves. So Lori has actually put a link in for a randomized control study. And of course, it's gone and open on me. I didn't mean to open it. Let me get my Zoom back. Sorry, really touchy computer. And so it's really comparing 2 versus 5 people in the OR when opening.
Oh, excellent.
So that would be something for all of us to maybe have a look at. So thanks for sharing that, Lori.
Love that, Lori.
Yeah, I love that word, like linking things. Perfect. It's more important now that than ever that increasing prevalence of the carriage of antibiotic resistance. You're right in terms of MRSA, VRE, et cetera. We have fewer tools to treat some of our patients who are really at risk. So
that's a very extremely good point. I didn't go into that, but I do have a little presentation on sort of our last line of defense, you know, where we're at with antibiotic treatment and how we're paying the price for widespread use of antibiotics over the years. And there hasn't been a new antibiotic discovered in quite a while. So, yeah, so very important point.
I'm just going to check the Q&A because I thought I saw something in here, but I was mistaken. So I think we're up to date on all of the comments. So some good discussion. Definitely the content very relevant, very well researched. Thank you so very much, and a great presentation this evening. I did want to take a minute to personally thank James Mishner from STERIS because you are the one that made this happen tonight by funding this event. So thank you very much. And I know Eva, she's not on the screen right now, but has done a lot in the background to help facilitate as well. So thank you so very much. And lastly, of course, to Lena, thank you for sharing your expertise and your time with us this evening. As always, you do a wonderful job presenting the content, whatever the topic might be. And you've certainly given me some things to think about and take back to my team. So thank you.
Thank you guys. Very much
so
appreciate being here. Thank you. And I love Jessica's comment. She's quoted perineal fallout and has a really surprised face. No. That's so funny.
Like, we don't want to know about that.
True story. True story. Okay. Thank you guys. Have a wonderful rest of your evening. I really appreciate your time, and it was a pleasure spending some time with you guys.
And it's Happy IPAC Week as well. Lori has more comments to say, so I love that. Thank you very, very much. Have a great night, everybody, and we'll see you all very soon. Good night.
Bye, guys.
Good night, everyone.
Perfect.